All right, I'm happy to be joined by infectious disease expert. You know him from his hits on Morning Live and probably on your TV or your phone elsewhere. It's Mr. Dr. Zain Chagla. Thanks for joining. Let's get right to it. I hear this all the time, monoclonal antibodies, whether it's on podcasts. I know Dr. Kieran Moore talked about it. Just briefly, last month, he said, treatments, monoclonal antibodies, and then just kind of kept going. And I started seeing that you're doing a pilot project with St. Joe's. And for those who don't know at this point, what is the difference between a vaccine and a treatment?
Yeah, so this treatment is actually not dissimilar to what vaccines would do, right? So when you get a vaccine, or if you have COVID-19 without being vaccinated or just naturally, you create antibodies. Your body creates these proteins that stick to the outside of viruses, that prevent them from getting into cells, that trigger your immune system to then clear out viruses, which is why vaccines work really, really well, is that you've already made this response beforehand. So when you see the virus, you have the armamentarium to deal with it. Monoclonal antibodies are very similar in the sense that they've looked at humans and said, okay, what are the antibodies that bind to the virus the best? Which proteins are there? And then the companies basically take them to the lab, they synthesize them in high quantities, and then we just put them into patients as an intravenous infusion when they're early in their COVID-19 to really give them those extra antibodies that do exactly what our body's antibodies do, that they would bind to the virus, prevent it from getting into cells, and help clear out the virus, essentially.
Right. But if someone were to get COVID and they weren't vaccinated, a vaccine won't help them treat COVID. That's where the monoclonal antibodies, that's what they do.
Yeah, exactly. So, when you get vaccinated, it takes a little bit of time for your body to build up those antibodies, make a response. So vaccination after COVID-19 doesn't work really well because it takes a little bit of time. Whereas if you can just give really large scale doses of antibodies rather than your body making them, you get the same effects basically.
And so we know what antibodies are. I'm acting as if, I'm in grade 5. Like, what is the monoclonal part? What is that?
Yeah, monoclonal is it's a scientific term. When we make antibodies to COVID-19, we make them to lots of different parts of the virus. And that's what's called polyclonal. So lots of different pieces. Poly is multiple, and clonal being different types. Monoclonal essentially is, one specific element of the virus or one specific antibody to the virus in that sense. So that's where that definition comes from. So this isn't like your body, which makes hundreds of different antibodies to COVID-19. This is a single type of antibody to a single part of the COVID-19 virus.
And so who makes the monoclonal antibodies? Do we have a contract with someone? Where is this coming from?
Yeah, so there's a number of different companies, Eli Lilly, Roche, and GSK. The product we use right now, the one that's accepted around the world because it's the one that still works against the Omicron variant, is made by GSK, a drug called Sotrovimab. But yeah, a lot of commercial companies that have developed these.
And so how long is this? It's a pilot project still, right? And so how many people have benefited from this, and what's the success rate?
Yeah. So we have been administering these since mid-October, just after Thanksgiving. We've had about 150 or so people come through the clinic over the last while. They've been from Hamilton, but also outside of Hamilton. We've had really good success. And so the clinical trials suggested, a 70 to 80% reduction in hospitalization. We pick people that are higher risk. So we don't give this to everyone, right? We don't give this to a healthy young person that we think is going to do well with their COVID-19. We give this to the 80-year-old or the 70-year-old who has multiple medical issues that we are worried that will not do as well with their COVID-19. And so, that population has about a 10% risk of hospitalization. We have seen less than 5 hospitalizations of people who have gotten therapy. None of those patients required a mechanical ventilator, and none of those patients died. All of them were discharged from hospital even after their hospitalizations. That means, about 145 patients that never even saw the inside of a hospital, despite them having a 10% risk of being hospitalized.
And is this does the treatment have multiple appointments, or is it just one, or how does it work?
Yeah, single appointment. So we give the antibodies. They're done through an intravenous. It has to be given within 7 days of people developing symptoms. They come to the clinic, a nurse, consents them, gives them an intravenous, administers the IV for about an hour. We keep them around for about an hour afterwards to just monitor for any side effects, which we haven't seen yet. And then they go home back into isolation, and often, even by about 24, 48 hours later, they actually start feeling a lot better. So the fever settled down, the muscle aches and tiredness settled down. And again, these are patients that a lot of them should end up in hospital that aren't ending up in hospital.
That's wild. And how does, I know it's all on the website as well, but how does someone who is at risk, 70 plus, 80 plus, with comorbidities, how do they find themselves at the clinic? How do they do that?
Yeah. So number one, the biggest, if you're a person at risk who's having symptoms, is try to get tested. And, now the province is prioritizing testing to individuals who are considered high risk. And so you should be at the front of the line in many places, including the city of Hamilton. So, get tested and get a result as quick as you can. There is the referral information on the website, and the best source to kind of get referred is through your primary care provider, because they can often validate your medical history that you meet criteria for that part. For people who don't have a family doctor who can't access them in a timely manner, the contact information for the clinic is there on the website. Call and leave a message. We may not be able to get back as quick as we can, just because we're, obviously with everything going on, there's a lot of demand for treatment. But we will try to screen patients and let them know if they're eligible, and if they are, book the appointment at that point.
So there's the demand that's definitely there. And, I don't know what the wait list is like. You can mention that if you like, but at what point do we say that, the stamp of approval, this is working, let's get this to all the major hospitals that are, the hot spots? I know Hamilton's not been doing great with COVID cases, but, send it to Peel region and, Toronto. At what point do we start seeing these treatments everywhere?
Yeah. So, we try not to keep a wait list, because the fact that this is time sensitive, right? So we have to get the drug into patients by day 7. Unfortunately, if they call us on day 7, we may not be able to get to them on that day, but we have been able to accommodate same days if they're urgent. Yeah, absolutely. Look, the pilot has worked. The province, this was a partnership with the province to kind of say, hey, can we make this work in a large scale setting, doing 5 to 10 doses a day, and then make it safe and make it effective and be able to reach out to our communities. The province has taken our data and are setting up a number of regional sites based on our business model in terms of how to run these clinics. So, for people who are listing outside of the Hamilton area, there will be much more access to this drug in many other sites across the province. That, again, it'll be for high risk patients, not everyone, but the hope is, that this could be distributed equitably within, a half-hour drive to most people's homes.
Yeah, and so that seems to be, at least that's what the WHO is saying, and even Dr. Kieran Moore last month and a couple of weeks ago, that seems to be that light at the end of the tunnel. Like, we know that we could try to vaccine our way out of this, but treatments for those at risk, the people who are ending up going to hospitals and clogging the ERs and the ICUs, are the people who are at higher risk. And if we can get them out of, not even go with these treatments, that's kind of the next stage. So is it fair to say that if we start having this widespread, we can start hopefully clawing our way out of this?
Yeah, absolutely. Like, this is a great tool. And, I think we recognize, even with vaccines, they're incredibly effective. They've reduced the risk through a huge amount of the population, but there are going to be groups that are always going to be at risk. Those are who are immune compromised, those are who are elderly, those with a lot of major medical conditions, but even a mild case can lead people into hospital. And so, again, throughout all of this, we need to take care of those populations first and foremost. And these therapies offer a big benefit there. And as supply gets better and hopefully gets standardized, even for lower risk populations, they may have access to this as well. So, this is really, exciting. This is different than 2020 and trying to deal with COVID-19. We are, dealing with 2022 and therapeutics and multiple tools in the toolkit. Customizing, making sure that highest risk patients have access as an extra layer of protection for there is going to benefit us all. It's going to keep our healthcare system healthy, and is going to, make sure that people, even if they do get COVID-19, recover at home with a benign outcome.
Right. And do we know, I guess this is something I should probably pose to the province, like, do we know when we could start seeing these regional outlets having the therapy?
Yeah, I mean, I think it's in the next couple of weeks you will see them open up. Obviously, staffing is super difficult with everything going on, and so it's been really, really tricky. But yeah, absolutely, we have there's discussions to make sure that these are available sooner rather than later.
Are you able to weigh in on the other types of therapies that kind of coming down the pipe that you can kind of preview that people can maybe look forward to?
Absolutely. So, there are a couple of other therapeutics that are available for people who can't access this right now. Some repurposed drugs, so inhaled steroids, so puffers can help with certain high-risk patients and help with their symptoms. There's an antidepressive called fluvoxamine, which is an interesting drug because it also tempers down inflammation significantly. And in a McMaster trial, actually showed a significant benefit to reducing hospitalization. Not as high as the monoclonals, but for something that's cheap and relatively accessible, still 30% reduction. And then we have a number of these other antivirals coming to the market: the Merck product, molnupiravir, and the Pfizer product, Paxlovid. And again, given to the right patients, we see 30 to 80% reductions in hospitalizations. They should hopefully come soon. And I think, again, we will likely have limited access up front and then more access as time goes on. But again, similarly, these networks of making sure that we have the right patients, they have access to testing, and they have access to a therapeutic. It may not be a monoclonal. It might be one of these pills or some combination thereof. It's really exciting that again, those highest risk people we can keep taking care of regardless of what's happening in our community. We can make sure that they're captured and they have as safe an outcome as everyone else.
And so what role does the nurses have in this as well? Because Maria Hayes, who kind of connected us, talking about, we're going to talk to a nurse later. How important are they in this whole process?
Yeah, so we have three major nurses, and I'll mention them here: Carling, Joy, and Amanda, who have been incredible. And we sat down together at the beginning of this to try to build a plan, to try to makeshift this, to innovate, to kind of deal with the some of the challenges. And Carling, Joy, and Amanda have been incredible. They've been advocates. They've been, talking with patients. We do have unvaccinated people coming through, and they've created a completely non-judgmental space so that they access therapy and everyone has the same outcomes. And they've been incredible. They've taken this on and made a program that is fully functioning, that they run from beginning to end, that they go from triage and referral to education all the way down to comfort and care. I think, again, as we set this up across the province, there's great collaborations between physicians, nurses, pharmacists, to really make sure that patients have access to these therapies, and again, that they're champions for people to get access.
And you mentioned unvaccinated people, and they're at risk. We are aware of how effective vaccines are. For those who have opted not to get a vaccine, they are being vilified. But like you said, it's a safe space. How would monoclonal antibodies help with people who have no protection at all from COVID?
I mean, it's that, right? It shortcuts their immune system to kind of deal with the virus. So it's not as effective as a vaccine, but it is pretty good. And so again, an unvaccinated 7-year-old with medical conditions, we know is going to be represented in healthcare if we don't get to them early. And so again, we make sure these therapies are available to them. We create environments that are very non-judgmental, non-biased, that those people can have access to them, as quick as they can. And at the end of the day, we're charged with treating patients, regardless of the choices they've made in life. There are so many sectors of medicine where we treat patients. We don't treat what they've done prior to that point. And this is very, philosophically the same. We treat patients, and that's about it.
Cool. All right, Dr. Chagla, I do appreciate it. We appreciate all the work you've been doing, informing us in a clear and concise way since this all started. And, hopefully those appearances start going down.
Yeah, I hope 2022 is the year I get off CHCH, let's say.
I feel like if the WHO is saying, 2022 is.
Yeah, it sounds like it.
Getting out of this, I think I'd be excited about that.
Awesome. All right.
Thanks
All
so
the
much.
best.
Take care.